Dear Chair, dear audience, let me present my research topic about extraintestinal manifestations in inflammatory bowel disease. My name is Ágnes Tímár, I'm a PhD student and a pediatric resident, and I have a vision to improve the quality of life of IBD patients through proper treatment. And to achieve that, my mission is to assess long-term disease outcomes and treatment options of IBD patients with extraintestinal manifestations. So I have two ongoing projects, both of them are focusing on extraintestinal manifestations. In the first one, we assessed the frequency of extraintestinal manifestations during advanced therapy by conducting a meta-analysis. So let's start with its importance. Anti-TNFs have been known to be effective in IBD and revolutionize its management. However, approximately 1/3 of the patients experience loss of response within 3 years, and in these cases, new therapeutic drugs are available. There is a vulnerable group of patients within the IBD population, approximately 10–25% of them, who will develop extraintestinal manifestations. These patients face a greater challenge in their daily living due to greater symptom burden, higher peer burden, and impaired quality of life. Therefore, it is highly important to adapt the treatment to cover the extraintestinal manifestations too. So here I would like to highlight our treatment options very briefly. On one hand, there is ustekinumab, tofacitinib, and upadacitinib, which all have a systematic effect, and they are already applied in other immune-mediated diseases. And on the contrary, there is vedolizumab, which is a gut-selective drug, therefore it is expected to have less effect on extraintestinal manifestations. So our aim was to determine which of these drugs is associated with the lowest frequency of new extraintestinal manifestations. So we investigated IBD patients who received advanced therapy, and their primary outcomes were new extraintestinal manifestations, and the secondary ones, improvement and worsening of already pre-existing extraintestinal manifestations. And we hypothesized that the frequency of extraintestinal manifestations will be the highest in patients who are on gut-selective biologicals. So we conducted our systematic search in 4 databases, which resulted in more than 13,000 hits. And during the selection process, we were able to reduce it to 61 eligible articles. So let's proceed with the results. In general, in all of my forest plots, proportion was used as measure of effect, and subgroups were formed based on the applied drug type. So, as I mentioned, what we hypothesized that the frequency will be higher in case of vedolizumab-treated patients compared to the ustekinumab subgroup. However, it did not reach statistical significance in this forest plot, where all of new extraintestinal manifestations were pulled together. As these are distinct diseases, we decided to analyze them separately as well. So this plot shows pooled proportions of new joint, skin, and ocular manifestations. And here you can see these manifestations are quite rare during advanced therapy, and there was no significant difference between vedolizumab and ustekinumab-treated patients. As secondary outcomes, we also investigated change in already pre-existing extraintestinal manifestations. So these 2 plots show improvement and worsening in case of a pre-existing joint manifestation. We can see here that improvement rates were significantly higher in the ustekinumab subgroup, whereas worsening rates were significantly lower in the ustekinumab subgroup compared to the vedolizumab-treated patients. Our biggest strength was that we were able to include a relatively high number of studies and provide a detailed subgroup analysis. However, we had to deal with non-standardized reporting system for extraintestinal manifestation as a limitation. So to conclude, we can say that there was no difference in the occurrence of new extraintestinal manifestations among advanced therapeutic options. However, in case of vedolizumab, the worsening rates were significantly more common in case of a pre-existing joint involvement, and improvement rates were significantly lower. So we suggest there is no need to under-prioritize vedolizumab in cases of pre-existing extraintestinal manifestations, except where a joint involvement is already present. And for the research side, we suggest to come up with a more standardized reporting system regarding extraintestinal manifestations. So our article was published in January in the Journal of Crohn's and Colitis. And in the remaining time, I would like to introduce my second project, which is a registry analysis about the relationship between extraintestinal manifestations and intestinal disease severity in children with IBD. So the background is quite similar, but we know very little whether IBD patients who have extraintestinal manifestations experience a more severe intestinal disease course. So that was our aim, to analyze whether there's an association between the presence of extraintestinal manifestations and the intestinal disease severity. So we analyzed pediatric IBD patients, and we compared those who have had an extraintestinal manifestation at diagnosis with those who had no extraintestinal manifestation during their follow-up. And our outcomes were relapse rates, need for biological therapy, surgery, and steroid dependence. We hypothesized that patients who have extraintestinal manifestation have a higher risk of poor prognosis of IBD. And we hope to define the role of extraintestinal manifestation as a prognostic factor. And we are working from the nationwide Hungarian Pediatric IBD Registry, and included IBD patients diagnosed between 2010 and 2020 who had at least a 1-year follow-up. So we were able to include 938 Crohn's disease patients and 531 ulcerative colitis patients. And regarding these baseline data that you can see here, there was no difference between the two analyzed groups. We performed a Cox regression analysis, and also we are presenting our results in Kaplan-Meier curves. So this Kaplan-Meier curve shows biological free survival in case of Crohn's disease patients, where we can see that those who had an extraintestinal manifestation at diagnosis received biological treatment significantly earlier. And this was also justified with the Cox regression analysis. Our next outcome is resection-free survival in Crohn's disease patients. Here we have interesting results that actually those who had no extraintestinal manifestations underwent resections significantly earlier than those who did have an extraintestinal manifestation at diagnosis. And moving forward to ulcerative colitis patients, here we can see the biological free survival. And although it was not statistically significant, we can see some tendency here that biological treatment was applied earlier in case where an extraintestinal manifestation was present. And in case of colectomies, those who had an extraintestinal manifestation underwent colectomy significantly earlier. So to sum up, extraintestinal manifestation at diagnosis regarding in Crohn's disease means a significantly greater risk for biological treatment, however lower risk for resection. And an extraintestinal manifestation at diagnosis in ulcerative colitis could mean a greater risk for biological therapy and a greater risk for colectomy. So these are my two projects. We plan to submit our second project next month. And as additional activities, I had the opportunity to present my results in several conferences. And we are also working on a questionnaire validation at Heim Pediatric Institute regarding food-related quality of life among IBD patients. So I would like to finish my presentation with a quote that the best preparation for tomorrow is doing your best today, and thank you for your kind attention.
How would you explain these results, like especially like the association between extraintestinal manifestations and resection, which was different for Crohn's disease and ulcerative colitis?
Yes, first we thought that it could be because they received biological treatment earlier, that it could be a protective factor for resection, but the COX regression analysis did not justify it. So we are thinking now that we need more event numbers, because there were 10 surgeries in case of Crohn's disease where there was an extraintestinal manifestations, and 98 in the no extraintestinal manifestation group. So I think that's the numbers are tricky here, and we need more cases to justify.
What were the numbers for ulcerative colitis?
It was the colectomy, like it was 7 and 13. So, but they were both low numbers, so it was more equal in this case.
My question is regarding your second project that you mentioned that you had pediatric patients, but what was the age range from this registry? Do you include infants as well?
Yes, so the most common onset of IBD is in the adolescent years, so they are mostly in their teenage years, but of course there are very early onset IBD patients in the registry, and they are included as well, but just a few patients belong to this category.
In the current clinical practice, which of the 3 methods is the most prevalent?
Like the drugs? You mean?
Yes,
So I work as a pediatrician, so in the pediatric practice, these second generation drugs are not really frequent, but in the adult population, they use vedolizumab and ustekinumab as well, and there are also patients who are treated with tofacitinib today, but this is a more expensive drug and not really used in Hungary yet, but I think in the future it will be more frequent as well.
You have mentioned the relapse rate as an outcome. Did you find any differences regarding that outcome?
No, and I have a backup slide for that. It shows actually relapse-free survival. I didn't have time to show this as well, but here you can see in the Kaplan-Meier curves that there was actually no difference in either Crohn's disease or either ulcerative colitis.
Just a very simple question. I'm sorry if I have missed something, but time trends in trends. Could they play any confounding role here, given the kind of given the changes in the incidence of new disease and perhaps also changes in treatment practices?
Sorry, I could not hear the first.
Time trends, could they play a confounding role here? Just if the indications of the treatment have changed over time, and of course if the incidence of the diseases have changed over time. What was the time period?
So the follow-up times were really...
No, the time period of diagnosis or the start of treatment.
Oh, okay, so we could not analyze this, unfortunately, but I'm sure that this could be a confounding factor, that what was the disease duration, but we did not have enough data, unfortunately. So I think that's one of the biggest confounding factors, and also concomitant treatment was not always reported. So I think these two could be play a huge role.